Good afternoon, everyone. I think we'll get started. It's 1:45. Welcome to this rapid fire session on Oculoplastics in orbit. My name's Simon Taylor. I'm filling in for Brett O'Donnell, who unfortunately couldn't make it up to Brisbane. So I'm from Sydney, and Lindsay McGrath here from Brisbane will be the moderators and helping. The first thing I'd like to do is read the acknowledgement of country. So the Royal Australian and New Zealand College of Ophthalmologists, members and participating guests, wish to acknowledge the Aboriginal and Torres Strait Islander peoples of this country, sovereign custodians of the country. We acknowledge their continuing presence and their contributions made to the college and the communities we work in. We'll respect past elders and communities, and will continue to live, work and interact in a respectful manner with present and future elders and communities. The RANSCO Reconciliation Action Plan reflects the messages of its First Nations engagement. Thank you. So the first speaker we'd like to call is Terence Ang. I've asked the speakers to keep on time. They have 5 minutes to present. We'd like to ask the floor to ask questions in the 2 minutes that follow. So thank you. So please send your questions in, or why don't you even just stand up and speak up? Thank you.
All right. Good afternoon. I'm Terence, and today I'll be presenting the utility of autoimmune markers in orbital inflammatory disease. So orbital inflammatory disease may be due to specific localized or systemic inflammatory diseases. However, if no underlying cause can be identified, then a diagnosis of non-specific orbital inflammation, NSOI, can be made. Serology may form part of a diagnostic approach for various immunogenic causes of orbital inflammation. So we investigated the utility of various autoimmune markers in screening for immunogenic OID. And these markers included ACE, ANA anchor, ENA anti-CCP, and anti-double-stranded DNA antibody. It was a single-center cross-sectional retrospective study, and we included patients over the age of 18 with a clinical, radiological, or histologically confirmed OID who had autoimmune markers conducted at initial presentation. We excluded patients with thyroid eye disease, patients who didn't have any autoimmune markers, and infectious orbital disease. So we had 79 patients, 28 of them had a specific diagnosis, and the remaining 51 patients had NSOI. And this was further classified with 20 being diffuse, 20 having dacryoadenitis, and 11 having myositis. Now, of the 27 patients with a positive serology, 63% of them underwent a biopsy, and 52 patients with a negative serology, 57.7% underwent a biopsy. And there was no significant association between the serology results, so whether that was positive or negative, and the patient undergoing a biopsy. And of the 12 patients with a positive serology and a specific diagnosis, only 5 of these patients had concordant serology, and 3 of these patients still proceeded to a biopsy. Regarding the individual markers, 2 patients had an elevated ACE levels, and this represented 2 out of 3 of the cases of sarcoidosis. 73 patients had an ANA, and 19 patients were positive. And of those with ANA positivity, 13 patients had NSOI, and this represented 26% of the 50 NSOI cases that were initially screened with an ANA. 72 patients were tested for ANCA, and 6 of them had ANCA positivity. All 6 patients with orbital GPA reported negative ANCA titers at presentation. However, 5 had previously known systemic disease and were on maintenance therapy and therefore had decreasing or negative titers. 1 patient, however, had new onset sino-orbital disease, but seroconversion only occurred at 3 months follow-up. ENA was screened in 53 patients, positive in 3 patients. Both patients with Sjogren's syndrome had a negative ENA. And anti-CCP was measured in 26 patients with 1 positive result, and that was a patient who was diagnosed with rheumatoid arthritis and secondary Sjogren's syndrome. And finally, none of the 38 patients tested for anti-dsDNA had positive results. Now, the results show that only a small proportion of patients with specific OID are supported by concordant serological results at the time of presentation. They remain an adjunctive investigation used along with radiological tests for diagnosing specific OID. And additionally, many of these patients previously might have known systemic involvement, have a diagnosis only confirmed at follow-up, or they may still proceed to a biopsy for histopathological diagnosis. Serology was unable to exclude nor differentiate NSLY from other specific causes of orbital inflammation. However, there are some study limitations, and these include the small sample sizes that were represented by each specific condition. Secondly, the GPA patients were on maintenance therapy, which are known to reduce or cause the negative ANCA titers. And finally, although the heterogeneity of the autoimmune markers tested at presentation and at subsequent follow-up reflect the clinical pretest probability of a specific diagnosis, various orbital conditions, such as limited GPA-related orbital disease, are known to present with seronegative disease. Seroconversion of autoimmune markers in patients with orbital disease remains to be explored, and longitudinal analysis may help to investigate the utility of serotesting in initially seronegative disease. So in summary, autoimmune markers often have a limited utility in screening for immunogenic OID. The choice of autoimmune markers in initial diagnostic workup of OID should be selective and rationalized by the clinical radiological presentation, as a full panel approach may yield non-specific findings. In many circumstances, the decision to proceed with a biopsy occurs independently of the serology. Thank you very much for listening.
Do we have any questions? And Terence, you had about 60% in both groups that ended up having a biopsy, whether they had positive or negative serology.
Yes, that's
So
right.
what other factors influenced whether patients had a biopsy?
So from the study, the decision to undertake a biopsy still remains quite multifactorial. So whether that's an treatment-resistant disease, an atypical disease course, and what we know is that, for example, in elevated ACE levels, they're quite predictive of having a high yield on the biopsy. So even if you have an elevated ACE level, for example, you still proceed to a biopsy to confirm a diagnosis. So those are some of the factors that affect the decision to undertake a biopsy.
Thanks. Yeah. Okay.
Thank you.
Terence. Next up, Dr. Carmelo Macri presenting magnetic resonance daguerreocytography showing delayed tear transit in functional epiphora.
Hi, my name's Carmelo, and I'm presenting our study, Magnetic Resonance Daguerreocytography Shows Delayed Tear Clearance in Functional Epiphora. The authors have no disclosures. So, functional epiphora, or non-anatomical impaired lacrimal drainage, is a poorly understood and controversial phenomenon. There is limited consensus on standardized objective diagnostic criteria, and the role of lacrimal imaging in functional epiphora is incompletely understood. Daguerreoscintigraphy, or DSG, has previously been used to demonstrate physiological dysfunction in the setting of functional epiphora. However, DSG exhibits significant limitations, such as high inter-observer variability and wide variation in quantitative transit times. Magnetic resonance daguerreocystography, or MRDCG, is an alternative physiological imaging modality that provides concurrent anatomical detail. Thus, we sought to investigate the presence of qualitative and quantitative MRDCG abnormalities in eyes with functional epiphora with comparison to values in asymptomatic eyes. We enrolled consecutive prospective eyes with suspected functional epiphora at the Royal Adelaide Hospital between 2016 and 2022. The definition of functional epiphora required patency on syringing, patency on daguerreocystography, or DCG, and an abnormal DSG, and no other identifiable cause for epiphora. Eyes were excluded if they ever had surgical intervention for lacrimal outflow obstruction, reflex tearing, lower lid malposition, laxity or paralysis, a punctocanalicular cause, pathology on rigid nasoendoscopy, acute daguerreocystitis, or a mucocele. We performed MRDCG using a time-resolved three-dimensional sequence known as TWIST, shown in Figure 1. During this sequence, 0.5 mils of 1% gadolinium was simultaneously administered to the medial canthus of both eyes every 2 minutes via intravenous connecting sets. Scans were performed supine, and participants were allowed to blink normally. The scan was performed over 25 to 30 minutes. We interpreted sequences for obstruction, stenosis, and patency. In addition, we measured the time to first appearance of the contrast in the sac nasolacrimal duct, and inferior meatus, and the time to fill the first 25, 50, 75, and 100% of the fundus to meatus distance. We compared the contrast transit times of the included symptomatic eyes with their 8 fellow asymptomatic eyes and a historic normative reference cohort of 17 asymptomatic eyes. We compared these groups using clustered two-sided Wilcoxon rank sum and signed rank tests respectively. We included 23 symptomatic eyes of 17 patients. The median age was 63 years, ranging from 17 to 82 years. MRDCG showed block in 16 eyes, stenosis in 4, and patency in 3. In comparison, DSG showed delay in 12, block in 9, and retention in 2. MRDCG was abnormal in 87% of eyes overall and showed a high rate of block compared to DSG, which showed more delay. The median transit times for the symptomatic eyes were 25 seconds to the sac, 63 seconds to the nasolacrimal duct, and 118 seconds to the inferior meatus. We found that transit times to the sac and the nasolacrimal duct were significantly longer compared to the normative reference times. In addition, contrast transit times to fill the first 25 to 75% of the fundus to meatus distance were all significantly longer. However, there was no significant difference when compared to the small sample of the 8 fellow asymptomatic eyes. In conclusion, MRDCG provides enhanced spatial and temporal resolution of drainage abnormalities compared to DSG in the assessment of patent but dysfunctional lacrimal drainage. MRDCG showed a high rate of block and detail of the associated anatomical location of abnormalities compared to DSG. In addition, given the median contrast transit time to the inferior meatus was 118 seconds, the final temporal resolution of MRDCG is better placed to detect abnormalities of tear clearance. Our study is limited by a small sample size, lack of comparison to a true control group, the elimination of gravity in the supine position, and a potential overloading effect of gadolinium. Further studies are needed to determine normative data in true controls and transit time thresholds correlating with symptomatic epiphora. Future studies should investigate the association of MRDCG findings with surgical outcomes. Thank you.
Thank you very much. Are there any questions? Scott Teskey from Queensland.
What does it cost to have an MRDCG as opposed to dacroscintigraphy?
I don't know the exact cost, but I assume it would be a lot more.
Could I ask a question? You said the delay time between the scintigram and the MRI is different, the transit time? And why do you think that should be?
Yeah. So we found that the sort of that median transit time was 2 minutes in the MRDCG. The variation with DSG is really wide. And I can't remember the numbers off the top of my head. I'm not quite sure what would be influencing that. There's a number of things. So that could be the gadolinium contrast is one of the confounding factors, the potential overloading effect of instilling lots of contrast in one go. And also, I guess, the resolution of the scan as well, in that it's hard to pick up the spots on the DSG as it's coming down. Mm.
Hence the temporal resolution is better at the bottom end of it.
Yeah, so the temporal resolution for the MRDCG is about 8.42 seconds per slice, whereas the DSG is in minutes.
Yes, that makes sense. Well, thank you. Any other questions? No, thank you. Thanks very much.
Thanks.
All right, next up we have Jessica Tong talking about functional epiphora with mucosal apposition, a new dacryoendoscopic feature.
Thanks, Dr. McGrath. So thanks, everyone. Today I'll be discussing mucosal apposition in functional epiphora as a new dacryoendoscopic feature. So functional epiphora, as we've heard prior, is defined as epiphora in the setting of an anatomically patent but dysfunctional lacrimal system. And currently the etiology is unknown. There are indeed regions of physiological narrowing in the lacrimal system, and as demonstrated in the diagram here, with number 2 demonstrating the valve of Krauss, which is located at the sac duct junction, we know that these exist. However, having physiological valvular regions should not be a cause of an obstruction to tear flow passage. Lacrimal scintigraphy, as we've also heard, can also demonstrate regions of pre and post-sac delay. But again, this does not reveal the cause for why the outflow delay occurs. So we attempted to address this question of etiology by retrospectively reviewing dacroendoscopies performed in patients with functional epiphora and where there were findings of mucosal apposition at either the sac duct junction or within the nasolacrimal duct at the time of surgery. Concurrently, all these patients also received nasolacrimal intubation with the nunchaku stents. And here I'll demonstrate a dacroendoscopy of what it should look like in a normal lacrimal system. So we're within the canaliculus here. We can identify that with the white mucosa and the central circular lumen. And we're here now in the lacrimal sac, identified by the more pink mucosa. And now we've arrived at the sac duct junction. And we can see that that's nicely patent. It's got an ovoid shape to it. And as the probe travels more distally, we can again identify that we're within the nasolacrimal duct. And as it goes further down towards the nasal cavity, the mucosa takes on a more red appearance, and the lumen can also be identified by the ridges in the mucosal folds. So it's important to be aware in dacroendoscopy what a normal lacrimal system looks like in comparison for the other types of pathologies. So altogether in our study, we identified 10 patients with 12 lacrimal systems who had mucosal apposition at the time of dacroendoscopy for functional epiphora. The mean age in our cohort was 68.8 years with a range between 56 to 80, and there was a slight female predominance with 6 women compared with 4 men in our study. Overall, there were 2 who had essentially unremarkable scintigraphy results, but 10 had evidence of post-sac delay, and the outcomes from intubation were quite underwhelming, with less than half having improvement after a mean follow-up of 11.3 months, with a range from 2 to 27 months. And here are just some diagrams demonstrating what the nunchaku stents look like. On the bottom left, it's demonstrating it sitting within the eye, and then on the bottom right, demonstrating the dacroendoscopic view as it goes into the lumen of the nasolacrimal duct. So mucosal apposition is what we've described as the walls of either at the sac duct junction or within the nasolacrimal duct either being completely opposed or being slightly opposed and having a slit-like appearance, and this lumen only becoming expansile with saline irrigation. So I'll just play the video while I discuss the different proportions that were found within our cohort. So 2/3 of them had this appearance at the sac duct junction, 1/4 were found at the mid-nasolacrimal duct, and there was 1 case found at the proximal nasolacrimal duct. And so what's demonstrated here in the videos is that you can see that open-close configuration where initially it's either completely opposed or very, very narrow, and then with saline irrigation, it comes more open. So the concept is that of a lacrimal system that is anatomically patent but highly resistant. And so the concept would be that the physiological lacrimal pump mechanism would be unable to overcome this level of resistance. So in conclusion, this study may demonstrate an anatomical etiological factor for functional epiphora, and it may show that mucosal apposition may in fact correlate with functional epiphora. And even though our results with intubation were not exactly promising, our study was limited by small numbers. In terms of future directions, it would be important to recruit more patients and determine if this is in fact a finding that is a normal variant. And if it's not a normal variant, it would be important to determine if this is what the incidence would be overall of mucosal apposition within the functional epiphora group. We would also welcome any expertise or advice from other groups and other centres for a multi-centre collaboration in order to be able to understand more about this concept of mucosal apposition in functional epiphora. Thank you.
Thanks, Jess. Thanks for keeping your time. Some questions, Dr. Hardy.
Just remind me how many normal dacroendoscopes had been done prior to this?
Yeah, so approximately there'd be about 60 that were done over that time period, but we're still going through the paper records to find an exact incidence. The other issue would be that not all of the dacroendoscopies were recorded, and the other thing would be that sometimes dacroendoscopies were easier done in Asian patients as opposed to Caucasian patients, with a higher brow being a bit of a barrier to when you turn perpendicular to go into the nasolacrimal duct. So that's some of the confounders that we've come across in this study. But thanks for your question, Dr. Hardy.
Thanks.
Were they done because they had fellow eye that was symptomatic, or how did you recruit those patients to have a
So at the Royal Adelaide, for all patients who have functional epiphora or requiring nasolacrimal intubation, we do a dacroendoscopy prior. So that's the standard of practice there at the Royal Adelaide.
Any other questions? Scott?
How long did you intubate the patients for?
So it was quite variable. On average, they'd be intubated for about 3 to 4 months. Once it was removed, if the patient became symptomatic again, then we would re-intubate them, sometimes indefinitely if it wasn't causing any issues with discharge. But on general, it'd be about 3 to 4 up to 6 months.
And Dr. Rosser?
So can I ask, if you're intubating a case like this where you've got these flaps which are sitting together and you're taking your tubes back out again, why would you think that would change the situation?
Yeah, that's
I
a
mean,
good
if it's
question.
going through a stenotic area or area of scarring, but when you have this anatomical feature whereby your mucosa seem to sit together, I can't see why putting tubes and then taking them out would change the ball game.
I guess it was only sort of going retrospectively that we were able to identify that this could potentially be a correlation with the functional epiphora. And as I mentioned before, we're not sure if this would also be a normal variant. That's a completely valid point that, of course, if there is an area of apposition, it would go back to being opposed once the tube is out. And that's probably the reason why we had lesser results once the patients had their tubes removed. But yes, it may be that they would either need indefinite intubation or a more formal DCR. Thank you.
Thank you.
Yep. No, we didn't have any of that. Normally it'd have to be done in theatre, so I suppose that was one of the limiting factors, but it would be a good component of a future study. Yep.
Thank you. I'll take the liberty of asking a question. You said 5 of the 12 improved. Were there anything peculiar about those 5 that were different from the other 7 with their scopes?
That's a good question. I mean, from memory, there wasn't any particular demographic data that was different in terms of age, gender, or duration of their epiphora. And I guess the other thing would be the small numbers that limited sort of any statistically significant comparison between the groups there.
Thank you.
Thanks, Dr.
Thanks,
Taylor.
Jess.
Thanks, Dr.
Next is Dr. Kazar Rana, looking at lacrimal gland dimensions with MRI. He's a junior doctor with an interest in ophthalmology.
Thank you very much. My name is Kazar. I'm one of the students with Professor Selva. And today I'll be presenting on the normative dimensions of the lacrimal gland on MRI in an Australian cohort. So an understanding of the normative dimensions of the lacrimal gland is required to help diagnose pathological enlargement, which can be seen in a range of inflammatory and neoplastic diseases. Previous studies have focused on the normative dimensions, which have been mostly reported on CT scans. Fat-suppressed, contrast-enhanced T1-weighted MRI is the preferred modality for evaluating inflammatory or neoplastic disease of the lacrimal gland. And so the aim of our study was to present a set of normative values in an Australian cohort on fat-suppressed, contrast-enhanced MRI and investigate how these may be impacted by age and sex. We conducted a retrospective review of patients who underwent MR of the orbits, who had at least one normal orbit. Patients with bilateral disease, such as thyroid eye disease, or patients who had previous orbital surgery or trauma were excluded from the study. We looked at axial scans, and in the axial scans, we looked at the axial length, which was measured from the anterior to the posterior tip of the lacrimal gland. And we also measured the axial width, which was measured perpendicular to this distance from the medial to the lateral edge of the lacrimal gland. We also looked at coronal scans, and in the coronal scans, we looked at the coronal length from the superior to the inferior tip of the lacrimal gland, and the coronal width, which was measured perpendicular to this from the medial to the lateral edge of the lacrimal gland. In our study, we had 211 orbits from 138 patients with a mean age of 58 years. No significant difference was found in the lacrimal gland dimensions between the right and left side in patients who had both orbits measured, and there was also no significant difference for genders as well. There was, however, a significant negative correlation between age and the right axial length, as well as the left axial length. So in other words, as patients got older, their lacrimal gland axial length decreased. These normative data may be used to help diagnose pathological lacrimal gland enlargement on MRI in an Australian cohort. We found that increasing age was associated with a reduction in lacrimal gland axial length, and this has also been shown in previous studies as well. This is likely due to age-related changes within the lacrimal gland, and there have been previous histopathological studies which have shown that with increasing age, there's an increasing prevalence of fibrosis and atrophy of the lacrimal gland. There have been some studies on extraocular muscle diameters which have suggested that males may have larger extraocular muscle diameters than females, and so a similar trend may have been expected for the lacrimal gland. However, we found no significant difference in the lacrimal gland dimensions between males and females. We used a simple and readily available technique to measure the lacrimal gland, which clinicians and radiologists can easily apply. There have been some previous studies which have focused on lacrimal gland volumes. However, these require segmentation of the lacrimal gland in consecutive slices and special software to calculate. So they're not at the stage where they're translatable to a clinical setting. Limitations to our study included the retrospective nature and the single cohort, as well as the fact that we looked at a single modality. In addition, it would be interesting to look at the CT findings in the same cohort. Thank you very much.
Thank you very much. Thanks for keeping on time. Any questions from the audience? Tom Hardy?
Measurements done by the same radiologist for all the scans, or were they done by yourself?
Yes, all the measurements were done by myself, but there were 20 scans that were then done by a neuroradiologist, and then we calculated the intra-class correlation of that.
You found a particular slice that showed it as fixed?
Yes, correct. Yeah, the maximum diameters, yes.
Could I ask, can you extrapolate that into a volume measurement? Well, that's too complex.
If you not really, but there have been some studies that have looked at extraocular muscles, and they have said that, for example, the medial rectus diameter is a good representation of medial rectus volume. So it is possible to have a look at future studies and calculate the volumes and see whether there is a correlation, whether the axial length or axial width could be used instead of doing volumes. So.
Right, thank you. And Tom, sorry.
No, we didn't, because retrospectively we went to the clinical records, and so we could exclude patients with thyroid eye disease or IgG4 disease, but we didn't quite have that information about the dry eyes.
Because I was just wondering, you had different numbers of right and left eyes. What were the reasons that you didn't do both on all your patients?
So essentially, we just looked at the normal orbits. So if patients had one-sided orbital disease, and we just looked at the left orbit, but then there were some patients who had both normal orbits, and so that's why there's a.
Excellent. Thank you. Thank you very much.
Right. Next, we have Dr. Jessica Seong talking about orbital plasmacytoma and multiple myeloma.
Thank you for the opportunity to speak to you today about orbital plasmacytoma and multiple myeloma, an Australian study. I'd like to acknowledge and thank all my co-authors for making this study possible. We have no financial disclosures. So multiple myeloma is a hematological malignancy, and it's characterized by monoclonal proliferation of plasma cells in the bone marrow. It's the second most common hematological malignancy after non-Hodgkin lymphoma and affects patients that are 40 years or older. Extramedullary plasmacytomas occur in about 3% of patients with multiple myeloma, and orbital plasmacytomas are even rarer, with less than 200 cases reported in literature to date. So our series aimed to provide an Australian data and perspective to describe the clinical and radiological features and outcomes in patients with orbital plasmacytomas. we performed an Australian multi-centre retrospective review of orbital plasmacytoma and orbital involvement in multiple myeloma from 2005 to 2022. To date, we've collected 21 patients, but we're just presenting 16 patients with complete data today. Demographically, the median age of presentation of their orbital plasmacytoma was 63 years, 56% being females and 54% being Caucasian. 94% of these patients already had a known diagnosis of systemic multiple myeloma prior to their orbital presentation. Of these, 73% were receiving active treatment and 27% were in remission. Their orbital involvement were mostly unilateral, and we had 2 bilateral cases. Clinically, the most common signs were limited motility, followed by diplopia, decreased visual acuity, and proptosis. Radiologically, on the right-hand side here, the most common orbital quadrant that was affected was superiotemporally. The radiological features on CT scan are similar to other lymphoid tumours, with diffuse homogeneous lesion, and sometimes they can have bony erosion. On MRI scans, they're often a lytic lesion that erodes into their bony walls with homogeneous T1, T2 signal and diffuse or moderate enhancement. On the right-hand side again, this graph shows the structures that were most likely to be involved in the orbit, with the most likely structure being the extraocular muscles. Of the extraocular muscles that were involved, the lateral rectus and the superior rectus were the 2 most commonly affected muscles. In our cohort, we had 12 patients that were biopsied and confirmed to have orbital plasmacytoma on histopathology. There was a high mortality rate of 63% for patients who had multiple myeloma-related mortality. In terms of the treatment modalities, these patients received radiotherapy most commonly, followed by IV and oral steroids, chemotherapy, and 12% of these patients had surgical debulking or stem cell transplant. So to date, this is the largest Australian series on orbital myeloma, and our study's results correlated with several other international studies. So in 2009, there was a retrospective review of 52 published cases from 1972 to 2009. Their mean age of orbital presentation was 56.5 years, and the most common symptom here was proptosis. 65% of these cases had a known diagnosis of multiple myeloma, and 35% proceeded to develop multiple myeloma after their orbital presentation. Again, there was a 75% or most common predilection for the superiotemporal quadrant of the bony orbit. In 2018, there was a series of 30 patients across multiple USA sites with no gender predilection and mean age of presentation of 57 years. 60% of these patients had a known diagnosis of multiple myeloma. 37% were then diagnosed with multiple myeloma after their orbital presentation, again with that superior or superiotemporal orbit predilection, and there was a 54% mortality associated with multiple myeloma. More recently, out of Moorfields, their orbital service, they found 20 patients from 1978 to 2020. Their mean age of presentation was 60.9 years. 50% had a known diagnosis of multiple myeloma, 25% later to develop multiple myeloma, and 25% had solitary plasmacytomas. For the mortality, those with solitary plasmacytomas had a better mortality of 20%. However, there was a high mortality of 73% with systemic multiple myeloma. On the right-hand side here are just some characteristic CT images of some patients in our study. So in conclusion, the majority of patients with orbital plasmacytomas already have a diagnosis of systemic multiple myeloma, or they go on to develop multiple myeloma at a later stage. So it's very important that we do identify these patients. They typically present with pain, progressive proptosis, diplopia, and compressive optic neuropathy. The quadrant that's most likely to be involved is the superiotemporal quadrant, and tissue biopsy plus or minus debulking is often recommended, although it's not always performed if there's already a history of systemic myeloma or if they're palliative. Orbital plasmacytomas are highly radiosensitive to external beam radiation, and there's often a very poor prognosis associated with systemic multiple myeloma, in which case the mortality is very high. And there's a clinical picture on the right-hand side of what it looked like intraoperatively for one of our patients. Thank you very much for your time.
Thanks, Jen. Jess. Any questions? And I'd invite the people at the back, come and sit down if you wish. Any questions on that difficult topic? I think one of the problems with that, if I could speak, is that we only see the patients who come to us. I think obviously with systemic myeloma, a lot of patients will get orbital disease, maybe asymptomatic and never present. So this will be a select group as well. Yeah. Any questions? Thank you very much.
Thank you.
Next, we'd like to call Jonathan Heyer on IgG4-related disease and lymphoma. John's not here. Yeah, Tom, are you happy to answer questions at the end, if you like? Come and stand in the firing line.
Hi, my name is Jonathan Heyer. I'm the OPAL Fellow at the Royal Victorian Eye and Ear Hospital in Melbourne. Apologies I can't be there to present in person. I'll be talking about IgG4-related disease and lymphoma in the ocular adnexa. We have no disclosures to make. So IgG4-related disease is a systemic disorder characterized by intense lymphoplasmacytic infiltration and tissue fibrosis causing progressive organ dysfunction. The orbit is a frequently involved site where it's termed IgG4-related ophthalmic disease, and nearly every orbital structure can be affected. Diagnosis can be difficult, and pathology consensus guidelines were published in 2012 and proposed revised diagnostic criteria in 2020 that grouped patients into definite versus probable versus possible IgG4-related disease. Serum IgG4 is elevated in many patients, but it can be normal in up to 30 to 40% of patients with biopsy-proven disease. So compared to the general population, patients with IgG4-related disease are at 3.5 times higher risk of developing malignancy, in particular ocular adnexal lymphoma. And a recent retrospective cohort study reported 7.4% of patients with biopsy-proven IgG4-related ophthalmic disease developed ocular adnexal lymphoma, which is 10 times higher than the risk to the general population. The vast majority are extranodal marginal zone B-cell lymphoma involving the mucosa-associated lymphoid tissue. Several hypotheses have been proposed regarding etiology, which is likely the result of chronic inflammation and prolonged antigen stimulation. So we performed a retrospective study. Patients were identified using the pathology database at St. Vincent's Hospital 2014 and 2022. Search terms included IgG4 and lymphoma, and 15 cases were identified. 3 cases were excluded as IgG4-related ophthalmic disease only with lymphoid hyperplasia rather than frank lymphoma. So for ease, I'll abbreviate ocular adnexal extranodal marginal zone lymphoma of MALT type to just marginal zone lymphoma. But it is important to differentiate IgG4-related disease from marginal zone lymphoma. I just wanted to make a note that 9 to 10% of patients with marginal zone lymphoma display IgG4 staining. So we grouped our patients into marginal zone lymphoma arising in the context of IgG4-related disease. So those were patients who had prior disease documented or polytypic IgG4 plasma cells in histology of IgG4-related disease concomitant with marginal zone lymphoma, or IgG4 secreting marginal zone lymphoma. And those had light chain restriction of IgG4 plasma cells plus or minus monoclonal Ig heavy chain rearrangement. And they could either be de novo, so not associated with IgG4-related disease, if only monotypic IgG4 plasma cells and no prior or concomitant disease, or those associated with IgG4-related disease. So overall, we had 12 patients. The overall mean was 52 years, 7 men and 5 females. All cases were extranodal marginal zone lymphoma of MALT type. Of those that had serum IgG4 levels measured, all were elevated. We had 8 patients who had marginal zone lymphoma arising in the context of IgG4-related disease, and they had a similar mean age of 54. 5 had prior IgG4-related disease, 2 had prior lymphoid hyperplasia, and 1 had prior Sjogren's disease with submandibular and lacrimal gland involvement. We had 4 patients who had IgG4 secreting marginal zone lymphoma. The mean age was 49 years, 3 men and 1 female. Of those, 3 patients had de novo disease, and 1 patient had prior IgG4-related disease. So in terms of location, 10 out of the 12 had bilateral disease, and the lacrimal gland was the most frequently involved in 8 out of those 12. And of those who had lacrimal gland involvement, 7 out of 8 were bilaterally involved. 6 patients had an orbital mass, 3 patients had involvement of the infra or supraorbital nerves, and 2 patients had involvement of the extraocular muscles. 2 patients had extraorbital disease. And of those patients we had data for treatment, 5 had radiotherapy and 2 had chemotherapy, and all had an excellent response. So in conclusion, the prevalence of marginal zone lymphoma and IgG4-related disease is comparable to other studies, and we only have a preliminary result at this stage, which is 12%, and that's comparable to Japan, Hong Kong, and Korea. IgG4 secreting marginal zone lymphoma can arise in the context of IgG4-related disease or de novo. And elevated serum IgG4 can be neoplastic rather than IgG4-related disease, and it's worth noting that. And to ensure that fresh tissue for flow cytometry or immunohistochemistry is collected when performing biopsies in suspected cases of IgG4-related ophthalmic disease. And treatment outcomes were favourable. Thank you for your attention.
Thanks, Joe. If you can pass our thanks to Jonathan. Yeah. Are there any questions from the floor? No?
Yes, Alex. Yeah, I don't have the exact details on that, but I presume that they were treated with standard doses like 20 gray. Most of them have, some patients do get treated with, the low dose radiotherapy, 2 gray. But in general, I think most of these would have had 20 gray. But I don't have the exact data. I'm just looking at the information on that. And I also assume, but on the basis of the fact that 5 had radiotherapy and only 2 had chemotherapy, that most of these were limited to the orbits and didn't have systemic disease, which is, again, following the typical pattern for ocular adnexal lymphoma.
So, Lana, did you?
So I think the databases was searched, the pathology database was searched for IgG4 disease and lymphoma, and then in those cases that had both diseases, that's what we extracted. Yeah. 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 So I think there was one patient that had some lymph nodes and submandibular involvement and hepatobiliary. One patient who had liver involvement, but we're not sure if that was IgG4 disease or not. And one patient had parotid disease. So, yeah. What do you mean by extraocular? Yeah. Mm-hmm. Oh, that's right. Yes. So again, I don't have all the details on that, but I think that I don't have the exact staging details on every patient, but I think most of them did have stage 1 disease, so limited to the orbit, one or both orbits.
Thanks.
Yeah, but we'll have to get back to you on that.
I ask one question. Some of those were de novo, and some had IgG-related orbital disease,
yep,
and then presumably progressed. What was the clinical situation that led you to take another biopsy? So what should we take away as clinicians to say we might have transformed? When should we take another biopsy? When has this progressed? Because I've certainly had more than one patient who declined the initial biopsy, and they might have lymphoma in there, I don't know.
Yeah, so I think I'd probably just answer in fairly general terms that if someone is not responding to immunosuppression, standard usually steroids for IgG4 related disease, or if they had a progressive change on the imaging, then that might lead to having another biopsy. So yeah, non-response to treatment, progression on treatment, perhaps recurrence after a period of quiescence off treatment, those would be the usual indications for a repeat biopsy.
And I understand these were sort of looking at the pathology, but does that fit with the clinical picture of these patients that transformed? Was there a reason why?
Yeah, again, I can't recall all the exact details for each patient for the IgG4 ones that had who didn't have primarily IgG4 secreting lymphoma. Yes, I can't recall all the exact details on those. I'd have to look them up, but I could get back to you on that.
We'll get back to you on that. Okay. Thanks very much, Tom.
Yeah. Next, Dr. Anna Marshter-Ribot presenting a new surgical procedure for lower eyelid reconstruction.
Thank you. Good afternoon. Well, we face scaring amounts of malignant eyelid tumors and some recur. Thus, the eyelid reconstruction remains challenging, not just because of the anatomical complexity, but also because of previous surgical iatrogenic morbidity. Thus, in lower eyelid defects, we have designed the marginal approach for releasing the lid with closure handling technique, also known as the Mudge technique. It was first described in a patient diagnosed with primary basal cell carcinoma who underwent a reconstruction of a full thickener lower eyelid defect in the middle of the eyelid. Within the next 3 months, we recruited 5 more patients, and they were operated by the same surgeon and center within a prospective interventional study. Talking about the technique, the name reminds us it's based on two main parts. Actually, for the first one, with the inferior canthalasis will shorten the horizontal defect somehow, though we will need to start with the splitting of the lamellae through the gray line and do the dissection over the interior surface of the tarsus below the orbicularis and the interior layer of the retractors. So the releasing of the lid is essential for the second part, the closure, because this will allow us confronting both edges of the posterior lamella. And with the dissection above the anterior layer of the retractors and the transposition, the immediate transposition of the anterior lamella will give us enough support for the posterior lamella. And with the releasing of the anterior lamella, we can decide where we want to put the remnant eyelashes, as well as we can create some skin folds that will benefit the reconstruction. For the closure, we can anchor the remnant posterior lamella to the medial tarsal edge, if there is any, or to the medial canthal tendon. Then we displace the anterior lamella medially, and we suture that. For this, we have to consider where we want to stitch the remnant eyelashes, and if it's worth increasing the skin incision to reach it. So the broader scope of this, to cover the skin defect, we use the folds created to guide us on the flap just below, and needed to, and just to assess the transposition that we need to the medial part. And the broader scope of this last part names comes from the fact that each patient will need an individualized closure, hanging on what I just mentioned about the eyelashes, about the particular things. And actually, this technique can be combined with others like tensile flaps or periosteal flaps. Actually, with the 6 patients recruited, the first 2 had a combined surgery. Those were the patients that had the biggest defect and had matarosis as the major complication. And we have to say that the main reason for those patients to have a combined surgery was that those were the first patients with this new technique to be done, and the reassuring of other well-known surgeries. The first patient had an associated tensile and an inferior lipectomy that caused post-surgical bleeding. And this other patient had a periosteal flap and a graft. So it seems that the Mudge technique would be a safe single-step reconstructive surgery. It's a tissue sparing technique in anticipation of possible future surgeries in recurrences and a halfway between laissez-faire and others like Hughes or periosteal flaps. It has a very good functional, a very good tolerance and comfort, and excellent functional cosmetic results with the ability to guide to the side where we want to lift the remnant eyelashes. And even though we know that we have a limited data, we have to recruit more patients and have a longer follow-up and assess its reliability with other causal lesions apart from tumors. It seems that the Mudge technique will allow us fixing those defects, those full thickness lower eyelid defects up to around 60%, while if we have bigger defects, it can be combined with other surgeries. And we have seen that even having a remnant defect on the tarsus, there are no negative impacts. So it seems that we can have a successful reconstruction of those defects. Thank you.
Thanks very much, Anna. Thank you very much. Any questions from the floor? No. So can I just, so none of the patients had a posterior lamellar reconstruction for that lateral part of the lid, and they've held up for the duration of follow-up. That's good news.
Yeah.
Thank you.
Thanks.
Any questions? No, thank you. Thank you, Anna.
Thank you very much.
Next, we've got JJ Kong speaking about dysthyroid optic neuropathy.
Thank you, Lindsay. I'm presenting on behalf of Dr. Ini Chung, who is the ophthalmology registrar. This is her work, and she's prepared a slide. 3 to 5% of thyroid eye disease patients will develop sight-threatening complications, most commonly due to dysthyroid optic neuropathy. As there is no clinical trial data to guide us, the best treatment strategy for DON remains unclear. Corticosteroid is currently the first-line treatment in DON in our center, typically given at 1 gram per day for 3 consecutive days or alternate days, and observation for 2 weeks to consider if urgent orbital decompression is required. This study aimed to determine the risk profiles and treatment outcome in DON using this treatment regimen at the Royal Victorian Eye and Ear Hospital. This was a single-center retrospective study between July 2015 to October 2021. The hospital pharmacy database for IV metalpred and the digital health records were reviewed. There were 1,234 IV metalpred cases identified during that period, and 85 of the patients have received IV metalpred for thyroid eye disease. 28% of the TED patients, that is about 33% of the TED cohort, were having IV metalpred infusions for DON. Charts were reviewed for their demographics, duration of TED, presentations, treatments, and the final visual outcome. 22 of the patients have data available for inclusion in the study. The median age of DON diagnosis was 58.7. We have 59% of cases were women, which is lower than the usual thyroid eye disease ratio of 4 females to 1 male. And 90% of patients were diagnosed with Graves' disease, which is consistent with the proportion of TED cases associated with hyperthyroidism. Over 80% were smokers. Most TED cases were diagnosed within 12 months of thyroid disease, and just over half the patient has bilateral involvement. The most common presentation was double vision, followed by proptosis, and RAPD was detected in 46%, which is consistent with the rate of unilateral DON. The average visual acuity at presentation is 6/19, with the worst case presenting at hand movement and best cases at 6/6. Most patients has predominantly extraocular muscles involvement, and half of the study population had documented apical crowding on radiology scans. The average cumulative dose of IV metalpred during DON treatment was 6.8 grams, so they have good going treatment. And the average cumulative IV metalpred dose until orbital decompression was 4.5 grams. With this treatment, our study shows that 41% of cases has good response to IV metalpred alone with resolution of DON, but 59% proceeded to need orbital decompression as they show persistent signs of DON. I find that quite interesting. Of this group, 32% had DON that was refractory to the combined treatment of IV metalpred and orbital decompression. I think it's a click. Yep. So 18% of them proceeded to have additional radiotherapy. 40% had additional immunotherapy, and 9% needed both radiotherapy and immunotherapy to bring DON under control. The patients were followed up on the average of 1.7 years. In this visual acuity plot graph, each dot point represents a patient. The red line is the logMAR visual acuity of the worst eye at DON diagnosis. Therefore, the higher the line, the higher the dot is, the worse is the vision. The blue line shows the final visual acuity. Overall, the VA plot graph shows an improvement in final vision in most of the patients at final follow-up. The overall vision outcome is good, with an average vision in the worst eye improved from 619 to 69, which is about a 2 lines improvement from the pre-treatment vision. Looking at all data combinations of fields and nerve findings and vision and color vision, DON was fully reversed in half of the cases, and 27% have residual signs. 100% of the patients have achieved inactivation of thyroid eye disease with that follow-up period. In conclusion, the DON cohort typically present in the late 50s, has a smoking history, and show predominance of extraocular muscle enlargement. First-line treatment with high-dose IV metalpred completely resolved DON in 41% in this cohort. A considerable proportion of cases need to proceed to orbital decompression. The study found a third of the cases were refractory to both IV metalpred and orbital decompression and require further treatments in the form of radiotherapy and immunotherapy. At the final follow-up, though, most patients retain good vision with an overall improvement of vision by 2 lines on the Snellen chart. So I'll take question.
Thank you very much. Thank you. And we have a minute or so for questions. Dr. Rosser.
JJ, can I ask, were those patients who needed decompression more likely to have proptosis or less likely in terms of kind of average proptosis you see in those patients? Within the greater degree of proptosis or the lesser degree of proptosis?
We haven't, the data was there for the proptosis measurement, but that was in the spreadsheet. So I can't quite tell you how proptose they are. But from clinical experience, some of them may not have a great deal of proptosis, but they still have DON. But we also have DON patients who are at least moderately proptose as well. I can pull out the data for you for these 22 patients. Yeah. I think it depends very much on their orbital configuration. Isn't it? I think it was really depends on whether the orbit is shallow, whether the configuration will cause venous congestion in the cases. I think that is definitely one of the factors. If you looked at radiology scan, at least 50% of them show apical crowding. That shows the orbital compartment effect.
In general, in the patients who had IV methylpred and proceeded to decompression, how many walls did you plan to decompress?
I'll get Tom to also comment, but usually we will do 2 wall decompression, lateral and medial. Yep.
Of the patients who failed everything, didn't respond to steroids, decompression, immunosuppression, do we know anything about them as were they heavy smokers? Did they have a longer duration of disease? Anything that might indicate why they didn't respond?
Well, a lot of them are smokers, and some did not stop smoking, and some are immunologically quite active on their bloods. I think most of the patients, when they have hypothyroidism, they are managed with the endocrinologist to make sure they are well controlled. We also have 1 or 2 cases that has every treatment given and has a bit of functional overlay of their problem. I could at least remember one of that we have to proceed with tocilizumab infusion. So I think, yeah, those are some of the factors.
There was a question on the floor.
I just wondered, have you correlated OCT findings around the optic nerve with the various outcomes?
There is a good point. We often do OCT for the patients, and some will show optic nerve swelling, but that is not in everyone.
I was going to ask a similar question, extend that to the ganglion cell layer, which you can now measure on the OCTs. Is that worthwhile looking to try and predict?
I think that will be worthwhile
compressive optic neuropathies.
I think that will be worthwhile as a research project to look at the correlations between DON and ganglion cells layer.
Much like the chiasmatic compression.
Definitely.
Thank you. Any other questions? Otherwise, I'd like to thank JJ. Colin. Next is Yinon here. Yinon Shapiro. Online recorded video, so no questions. Yinon's from South Australia, Adelaide, and he's going to return to the lacrimal system and talk about outcomes of intubation endoscopic DCRs. If we can get his...
Thank you for the opportunity to present our study, Outcomes of Intubation and Endoscopic DCR and Functional Nasolacrimal Duct Obstruction. Epiphora patients with a patent but dysfunctional nasolacrimal duct drainage, sometimes referred to as functional block, are commonly encountered in the lacrimal clinic. Nevertheless, the evidence regarding the preferred intervention in this scenario, namely lacrimal intubation or DCR, is limited. Furthermore, there is lack of uniformity in diagnosing and defining functional nasolacrimal duct obstruction. Therefore, in this study, we used clinical exam, Dacron cystography, and Dacron scintigraphy to define a homogeneous group of patients with functional nasolacrimal duct obstruction. This was a retrospective study spanning a decade in the Royal Adelaide Hospital Lacrimal Clinic. At our practice, patients with functional nasolacrimal duct obstruction are routinely advised there are two options for their primary treatment: silicone tube intubation, in which nunchaku bicanalicular tubes are used, or endoscopic DCR. We then proceed based on the patient's choice. We identified 23 endo-DCRs and 41 intubations, which were performed for functional nasolacrimal duct obstruction over the study period. We then assessed the success of these procedures based on the clinical follow-up. In addition, we prospectively telephoned the patients to attain longer follow-up outcomes using a telephone questionnaire. Now for the results. At a median follow-up of 9 months for the DCR procedures and 10 months for the intubations, there was a significantly higher rate of self-reported epiphora resolution, as well as of self-reported overall improvement in epiphora in the endo-DCR treatment group. Furthermore, among patients undergoing DCR at the primary procedure, only one, approximately 4%, had a secondary DCR revision. In comparison, among patients undergoing intubation as the primary procedure, 7, which is 17%, underwent a secondary DCR following the intubation. Phone audit results should be interpreted with caution, as we did not achieve high response rates, and perhaps more importantly, there was a significantly longer time that has elapsed since the procedure among the endo-DCR respondents. Nevertheless, the long-term audit teaches us that in endo-DCRs, the reported improvement rate diminished compared to the rate encountered in the clinical follow-up. Taken together, the results of this single-center retrospective analysis suggest that among functional nasolacrimal duct obstruction patients, improvement in epiphora may be expected in approximately 59% of intubations, while the success of endo-DCR is significantly higher at 91%. Secondly, preliminary evidence based on our phone questionnaire may suggest that the improvement following endo-DCR may diminish after several years. Finally, the next logical step, which is currently underway, is a randomized trial designed to substantiate these findings. Thank you very much.
Thank you. I guess Dr. Shapiro is not here to defend his thesis. Anyone from Adelaide who's happy to stand up and defend? Dr. Slattery, any comments? Jess just had to leave. She went back to Adelaide. Thank you. Okay, so thanks. Next, also from Adelaide, Ayman Usami, further discussing functional epiphora. Thank you.
I'd like to thank you all for giving us the opportunity to present our study, Functional Epiphora, an underreported entity. Post-hoc drainage impairment causes such as nasolacrimal duct obstruction, nasolacrimal duct stenosis, or functional nasolacrimal duct obstruction are known to be one of the most common causes of epiphora presentations. However, these post-hoc drainage impairment causes in previous reports are usually not differentiated and grouped under the same category, such as lacrimal system block or lower lacrimal duct obstruction. Therefore, it is uncertain what percentage of these cases actually constitute functional nasolacrimal duct obstruction, and thus functional nasolacrimal duct obstruction may be underrepresented in the literature. Moreover, there's a lack of standardization in diagnosing non-anatomical functional drainage impairment. Thus, we aim to retrospectively review the distribution of causes of epiphora in adult patients presenting to our lacrimal clinic, using a clear diagnostic criteria to investigate the burden of functional epiphora in our population. This was a single-center retrospective review. All patients underwent comprehensive clinical evaluation, including syringing probing, followed by lacrimal imaging, both dacroscintigraphy and dacrocystography. Functional nasolacrimal duct obstruction was diagnosed based on the exclusion of alternate causes of epiphora on clinical examination, patent lacrimal syringing, normal dacrocystography, and a delay on dacroscintigraphy. In terms of results, as you can see from the pie chart, post-hoc blocks were the most common causes of presentations, which is consistent with previous reports, almost 26%, with an almost equal number of nasolacrimal duct obstruction and stenosis cases. Interestingly, we found that non-anatomical or functional obstruction cases were just as common as anatomical nasolacrimal duct blocks, which were also 26%. Among the functional cases, post-hoc delays were more common than pre-hoc delays, 89% versus 11% of the total. Regarding other causes of epiphora, 11% of the causes were multifactorial and 16% of all epiphora causes were unknown. So, in conclusion, a high proportion of functional nasolacrimal duct obstruction cases were diagnosed once both dacrocystography and dacroscintigraphy were utilized in the evaluation of epiphora. Therefore, functional post-hoc obstruction may have been combined with other causes of lacrimal drainage impairment and hence underrepresented in the previous reports. These results suggest that a clear diagnostic criteria may therefore be necessary for differentiation, as this may have implications on the success of intervention and is therefore relevant for counseling patients before surgery. Thank you.
Thank you very much. You happy to take some questions? Any questions from the floor? Lindsay? Well, thank you very much.
Thanks.
Once again.
Yes, Terence is coming back to round out the session, talking to us about microbiology of bacterial orbital cellulitis. Thank you.
Good afternoon, I'm Terence, and today I'll be presenting again the microbiology of bacterial orbital in South Australia. So bacterial orbital can have significant implications on mortality and morbidity if not appropriately treated. Typical organisms implicated are Streptococcus species and Staph aureus. However, regional variations exist and are influenced by evolving epidemiological trends. So within this present study, we aim to update the existing literature with the microbiological trends that we've encountered in South Australia and characterize any associations with clinical features and outcomes. It was a multi-center retrospective study at 3 tertiary institutional centers in South Australia, and patients of all ages with a clinical radiological diagnosis of orbital cellulitis were included. Preceptive cellulitis was excluded. So this study had 99 patients between January 2012 and August 2022. The mean age was 22, ranging from 13 days old up to 91 years old, and there were 70 pediatric cases. 67.6 patients had an organism identified, and no organism was identified in the remaining 32.3%. And within this group, 34.4% of cultures were from the orbit and or sinus. Sinus and orbital abscess cultures had the highest yield of 73.7%, whilst blood cultures had the lowest yield of 11.7%. Organisms identified included Streptococcus species, Staph aureus, Haemophilus species, mixed anaerobes, and Enterobacter cloacae. And the remaining organisms, as listed here, they each made up 1%. So Streptococcus species and Staph aureus were both the most common organisms identified yearly, and proportions of isolated organisms remained relatively similar throughout the study period. Streptococcus species predominated in the pediatric population, and there was a statistically significant difference in mean age between strep species and Staph aureus. MRSA was isolated in 28.6% of all Staph aureus cultures, and of which 50% occurred between 2021 and 2022. There was no difference between MSSA and MRSA for mean age, duration of symptoms prior to presentation, or mean hospital duration. A greater proportion of MRSA cases developed a subperiosteal abscess and intracranial extension. However, the extent of statistical significance was unknown due to a small sample size. Our findings are similar with the recent microbiological trends that have been observed around the world. Strep species and Staphylococcus aureus were both the most common organisms cultured. And although our study demonstrated that strep species was more common in the pediatric population, there remains quite a mixed conclusions in the literature. Organisms such as Enterobacter cloacae, Pseudomonas aeruginosa, and mixed anaerobes remained quite uncommon, and they tended to be represented in polymicrobial isolates. MRSA incidence in the literature varies from 21% up to 73% and is likely affected by changing epidemiological trends and specific institutional and geographical locations. Our MRSA incidence we have observed is lower than some of the studies that have been conducted in North America and some Asian countries such as Taiwan. Our study noted that 32.3% of cases did not culture an organism. Cultures obtained from surgical intervention from orbital abscesses or sinus cultures had the highest positive identification. However, in the absence of cultures obtained from surgical intervention, cultures from ocular discharge and nasal swabs also provided a relatively high positive yield. Our study findings support conducting swabs of ocular discharge and the nasal passage in the first instance, and it reaffirms that the identification of a causative organism can be improved by collecting samples from multiple sources prior to the initiation of empirical antibiotics. There are several limitations of the study, including its retrospective nature and the small sample sizes that were represented by the uncommon organisms. A proportion of patients did not have any organism cultured. However, this ultimately reflects the challenges that are faced in clinical practice. The clinical outcomes of atypical and multi-drug resistant organisms and polymicrobial infections remains to be explored. So in conclusion, trends in microbiology have remained largely constant in SA tertiary institutions over the 11-year period. Staph aureus and Streptococcus species remain the most common organisms, and MRSA remains an organism of increased clinical and public health concern and may be associated with a more aggressive disease course. Thank you for your attention.
Thank you, Terence. I open the floor. Dr. Hardy. What was the yield rate for swabs that you've done before antibiotics were started from the nose or from the eye?
Yeah, so the our positive yields were calculated regardless of whether they had been started on empirical antibiotics or after. So I guess that's a confounding factor that we sort of recognize is that, you know, starting empirical antibiotics, whether that's in the primary health setting or initially whilst they're in the ED, for example, would sort of confabulate those results and possibly maybe underrepresentation. I think interestingly with the patients that had a sinus culture or had an orbital abscess culture and they still had no organism identified, from my reading, what I've understood is that sometimes the sort of cultures that are obtained from these sites, they might not represent true uncontrolled infection, whilst they might represent orbital spillover or orbital inflammation. Oh, okay. So the nasal swabs, the yield was about 70.6%, and the ocular discharge was about 54.5%. These results are quite consistent with the previous literature on microbiology. However, we do understand that whether that's concordant with the actual organism that's being identified, there remains a lack of literature in that area. Yeah, so in other studies, such as one done in about 2007 by McKinley et al. In the American Journal of Ophthalmology, they had positive rates up to 70% for orbital and sinus cultures as well. Yeah.
Any other questions? Could I take the liberty of asking
Yes.
one? The previous literature suggested children, the younger children, have only got one organisms, and older people have got polymicrobial infections. Is that what you found as well?
Yes, definitely. We had out of 99 patients, 8 of them had polymicrobial isolates, and there was a tendency for them to be in adult. I think 5 of them were in adults, 3 of them were in pediatric cases.
Right.
Yeah. And I don't think any of them were in the last year. I think in the last year, most of them were single organisms that were cultured. Yeah. Okay. Yeah. Is that at the women's and children's? I believe that in the recent, from just the start of this year to about August, there were about 8 or 9 cases, and they were the ones that we've included in our series. Okay.
So from this, will you be recommending certain antibiotics? I mean,
Yeah. So the
flucloxacillin,
antibiotics.
ceftriaxone, or whatever the local
Yeah.
flavour is there a change we need to make?
So definitely the antibiotics that are standard practice, for example, at the women's and children's would be either IV cefotaxime as a single agent initially, or IV flucloxacillin with ceftriaxone. Those are the sort of protocols that at the women's and children's hospital. And if there's any concern for like aggressive disease, usually vancomycin might be added. If there's a concern of anaerobic disease, anaerobic organisms, then something like metronidazole would also be generally added on as well, until those sort of cultures help guide us and sort of rationalize our antibiotics. But the empirical antibiotics still remain quite the same.
So they haven't added vancomycin empirically yet?
In some cases, they had IV vancomycin indicated, yeah.
And given
Any other questions? Thank you very much.
Great, thank you.
That'll bring the conclusion before we go to afternoon tea. We'd like to thank all the speakers. We appreciate it's an enormous amount of work just to do 5 minutes of presentation, and we look forward to the publications which will come from all this. If we could thank all the speakers once again, and look forward to afternoon tea. Thank you.